Welcome to the Johns Hopkins Medicine online webinar series. Today, Dr. Zimmerman will be speaking about types of cardiac imaging, what you need to know. Before we get started, we'd like to provide some user tips so that you're comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenter. The last 30 minutes will be dedicated to our live Q&A session. To submit a question, please type your question into the Q&A box and click send. Your questions will be seen by others watching this presentation, so please note if you do not want your name attached to your question, please check send anonymously. We will do our best to answer all questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. Please note this program is being recorded. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete a survey. A pop-up window will appear at the end of our program for you to complete the survey. And now I would like to welcome Dr. Zimmerman to begin our presentation.
Hi, good afternoon, everyone. Thanks for attending. It's great that you're interested in learning more about cardiac imaging. And so I will try to do that over the next 30 minutes and then we'll have 30 minutes of questions. This is going to be I'm going to try to keep things basic so that everyone can, understand and get an introduction to what cardiac imaging looks like and what it's being done for, and sort of what your experience might be if your doctor suggests that you should get some cardiac imaging. This is the title slide, the types of cardiac imaging and what you need to know. So I'm going to start just quickly talking about the parts of the heart and what the heart does, because that will give us kind of the basis to talk about why we do different types of cardiac imaging. So first, this is a picture of a heart that's generated from a CAT scan. And the heart here, we're looking at it kind of not exactly how it sits in your chest, but maybe a little bit off, like we're kind of looking down on it a little bit. And different parts of your heart here are the ventricles. Those are these big sort of red areas here, the left and the right. And then these sort of squiggly things, those are the coronary arteries. And so the coronary arteries are the things that we care a lot about in health. And those are the things that deliver the blood supply to your heart. And as we know, our heart beats throughout our entire life. And so we need a lot of blood supply in the heart in order to provide the heart with energy it needs to continue beating throughout the whole life cycle. There are several different coronary arteries. Here's one here. This one's called the LAD, or left anterior descending coronary artery. This one over here on the other side, that's called the circumflex coronary artery. And then that's called the right coronary artery. So when we're looking at patients' heart and trying to determine what's going wrong if patients are having heart problems, one of the things we think about is whether or not they could have abnormalities with their coronary arteries that might cause reduced blood flow to the heart. Now, the other thing that the heart's major function is to pump blood, right? The heart receives blood from the lungs, actually, which has been oxygenated by breathing. So we breathe in oxygen, it adds oxygen to the blood, and then it goes into the heart, and the heart pumps it out into the aorta. And that's this arrow here. So the aorta is this big guy up top. The aorta is the big vessel in your chest that supplies all the blood to the rest of your body, all the oxygenated blood. And so that's the function of the heart, is basically pump oxygenated blood out through the rest of your body so that your body's cells can, operate normally. Okay, so here's a picture of the chambers of the heart. This is actually a set of images from a cardiac MRI. And what we're seeing is the heart pumping. It's one of the cool things about cardiac MRI. We can see these things in pretty good detail. And there are different chambers in the heart that I just want to draw your attention. So we're starting from, so we can understand the different parts like I talked about. The cardiac chambers are made up of both atria and ventricles. And so it turns out that the first one is the right atrium. And this is the one that gets the blood from all around your body that come through the veins. So if you think about like the veins on the back of your hand and the veins like in your arms, or on your feet even, all those veins, eventually all that blood is working its way back into the right atrium. That's the target for all that venous drainage. Once it gets into the right atrium, then it goes into the right ventricle. The right ventricle is another chamber in the heart, and this chamber is squeezing. And so it's squeezing the blood out of the heart and actually squeezing it into the pulmonary artery and into the lungs. Once the blood moves through the pulmonary artery and the lungs, then it gets oxygen in and it returns into the heart via the pulmonary veins back here into the left atrium. And then from the left atrium, it moves into the left ventricle. So these are the different chambers of your heart that we care about when we're looking at cardiac imaging. And one of the things we want to look at are do these chambers look normal? Do the different chambers seem to be functioning appropriately? So let's talk a little bit about some sort of broad categories of diseases that we can look at in the heart. One big disease, like I mentioned already, is reduced blood flow. And so that's when you have coronary artery blockages that reduce the blood flow to the actual heart muscle itself. These blockages, when your heart muscle doesn't get enough blood flow, it's called ischemia. That means not enough blood to meet the demand of that tissue. So for instance, if you're exercising, the demand of the tissue for blood is higher because you're more active and you need more energy. And so a lot of times people have ischemia that happens when they're exercising because of that increased demand. The coronary blockages mean that you can't meet that increased demand and you get pain or things like that. You get pain, also known as angina, which is chest pain caused by reduced blood flow to the heart muscle. And then in the most extreme form of reduced blood flow is a heart attack. So that means that basically you have so little blood flow that the heart muscle itself is permanently damaged. And it's called infarction. And eventually, basically, those cells that form that tissue can die and be replaced by scar tissue, which does not function normally. So other diseases of the heart that we look at, they're diseases that are caused by having a weak heart muscle. So maybe not necessarily problems with the vessels in the heart, but rather a problem with the muscle itself. This can cause heart failure. So if the muscle of the heart can't pump blood like it needs to, then you get a condition called heart failure. This causes fluid to build up in the lungs or sometimes in your legs. And it causes shortness of breath. And difficulty exercising. So maybe you can walk a block or two and then get short of breath after that. That could be caused by heart failure. There are problems with the valves that can happen, and the valves are the things that separate the different chambers of the heart and make sure the blood stays where it needs to be. So you can have valve stenosis, which means narrowing of the valve, or regurgitation, which means a leaky valve. And what this can cause is your doctor can hear the changes by detecting a murmur on the stethoscope exam. If it's bad enough, it can cause heart failure because all that extra abnormal blood flow moving around can cause your heart basically to have difficulty moving the blood around and eventually lead to failure. Certainly, you can have trouble with exercising, and fainting is a big one actually for stenosis. If you have aortic stenosis, which is the valve that separates the left ventricle or the left side of your heart from the aorta, that area, if you have some stenosis there, then you can actually have fainting that happens. Okay. Then there are all sorts of rare, this is just a peek at some of the broad categories of diseases of the heart. And there are all sorts of other rare things that can happen. There's a category of diseases called infiltrative diseases. These are diseases where abnormal substances build up in the heart muscle and cause the heart not to function normally, including iron or amyloidosis, which is another thing, or sarcoidosis. And these are very unusual names. And unless you have that disease, you probably never heard of it. But for some people out there listening, they may have one of these diseases or know somebody who has it. There's congenital heart disease, which means that when you're born, some of the vessels may not be connected up correctly. And so basically the plumbing is wrong, meaning that maybe the right heart should be pumping to the pulmonary artery, but instead it's pumping to the aorta or vice versa. And so things aren't connected in the normal way, or there may be communications between chambers that don't belong. And that can happen with congenital heart disease. And then finally, tumors of the heart. Tumors happen everywhere in your body, and certainly the heart is a place it can happen. Fortunately, tumors of the heart tend to be pretty rare compared to other tumors like, that are more common, like breast cancer or colon cancer. Okay, so now that we have a little bit of an overview of what are different sort of problems and diseases you can get in the heart, let's talk about the types of cardiac imaging and how they can provide more information about those diseases. So one is echocardiography, or also known as cardiac ultrasound. This is a very common type of cardiac imaging that's done. Another one is nuclear medicine. Those are known as SPECT or PET, and they use a particular type of tracer or radioactive agent known as sestamib. Then there's cardiac CT, which you saw a picture of that already. And there are a couple of different flavors of cardiac CT. There's the calcium scoring, which is the simplest version, and then the coronary artery CT, where we actually use IV contrast dye, which I'll talk to you about later. And then finally, cardiac MRI. So here's a set of images from an echocardiogram. So this is an ultrasound, like I mentioned. And there's an ultrasound probe actually that's put on the surface of the patient's skin up here. And then from that ultrasound probe, I'm having some video issues here, sorry. Let's try again. From the surface of the ultrasound probe, you get these images coming back from the heart itself. And those images basically show cardiac motion. And you can look at, in this case, you were seeing a really nice view of the mitral valve here, opening and closing, as well as the aortic valve over here, opening and closing. Right there is the aortic valve, and right there is the mitral valve. And then around the mitral valve, you can see this sort of stuff here, and this stuff right here. That's actually the wall of the ventricle beating and trying to squeeze during the cardiac cycle. So echocardiography is a great test. It's easy because all you do is you put that probe on somebody's skin and you can take a look. Now, it's not so easy that I could just do it like walking off the street. I don't do echocardiography, and it takes quite a bit of training to know how to get the right views. But in the grand scheme of things, as far as patient preparation and things like that, it's very easy to put somebody on a table. And as long as you have a knowledgeable person who knows how to use the machine, it's very easy to get images. And it's relative to other things, it's fairly cheap, and it's fairly quick relative to other things. And so it's a really nice test that you may be asked to do at some point. Here's an example of echocardiography, which is has a slightly different spin to it. You can notice there's color now. And so why is there color? That's because the echocardiogram has been used with this color to show blood flow. In this case, what's doing is it's showing actually the ventricle blood flow from the left ventricle that's going the wrong way into the left atrium through the mitral valve. So this is an area of regurgitation. Now, and if you don't, if you haven't really looked at these, it's really tough to tell what's going on. It just looks like a blur, a big mess. But trust me, this is showing mitral regurgitation. And from this, you can grade the severity of regurgitation. You can determine whether or not the regurgitation needs to be fixed, things like that. Follow the regurgitation over time, and so on. So here's what it looks like if you're for the patient. You basically sit on a bed usually, and you're next to this big machine. This is a slightly older machine, so a little fancier now and maybe a little bit smaller. But basically you have the probe's attached to the machine. Usually there's some gel, ultrasound gel that goes on your skin. And then from there, the probe's moved around and you get pictures up here. And then there's all this keyboard. You can sort of, the technologist performing it, takes different measurements and things like that and gets a whole bunch of different pictures throughout the whole experience. So it's really good for looking at the function or the squeezing of the heart and also the valves and whether or not working correctly. There's actually two different types. The one we saw was transthoracic, which is the easiest on your chest. There's one that's a little more invasive called transesophageal. That one actually, believe it or not, it's like if you've heard of an endoscopy where they put a tube down your throat to take pictures, it's basically the same thing. It's an endoscopy, but instead of pictures with a camera, they're actually putting in an ultrasound machine that is then pointed from the inside towards the back of your heart, actually. And so only in very special circumstances do you need that transesophageal echocardiogram. And it's for if you have some particular questions about valves, sometimes it may be needed to get a better look at what's going on. Okay, so moving on to the next category, these are nuclear medicine tests. So I'm showing you some images from a actually PET. And so these are, so look kind of like strange, maybe weird images of something. It's hard to tell what it is. So I've just put in images from MRI just to give you some orientation as to what we're looking at. This case, we're looking at, this is called actually a short axis view of the heart. So we're looking at all the walls of the heart. So imagine this part here that's squeezing is this part here that's bright orange that's showing up. And then the same thing here, this is a different view. It's called a long axis view of the heart. And so this sort of U-shaped part of the heart is this part of the muscle that we see squeezing here is represented by this orange here. And so what happens when you do a nuclear medicine test is you give a patient some sort of nuclear medicine tracer. Usually it's called sestamib. And so that tracer likes to basically go into areas of the heart. And so we can see that actual tracer going into the heart muscle itself. And you can give that tracer in conditions that are rest conditions or stress conditions. And so stress meaning like almost like exercise, right? And so what you do is you give the tracer at stress and you give the tracer at rest. And in this case, you can see that there's an area of the tracer of this part of the heart here, which is not as bright at stress as it is in rest. And so that's also shown here. And so what that is it's called a perfusion defect, or even you could call it an area of ischemia, an area where there is not the same amount of blood flow during stress examinations, during exercise, more or less, as there is at rest. And so that means that your heart is having trouble getting blood flow to that area. And if somebody is having symptoms of pain when they exercise, pain in their chest, then this will tell you that most likely there's some sort of blockage here that's preventing blood from getting to this area of the heart during exercise. So here's an example of what a PET looks like. This is a PET CT. And so in this case, by the way, all these machines look really similar once we start getting into the CTs and the other things, but I'll show you some pictures just so you know. So the ultrasound, for sure, a self-contained little machine, but everything from here on out is going to sort of look very similar. So a PET CT is basically this round donut, and built inside of the wall of the donuts are two things. There's a CT scanner, as well as there are cameras that pick up the radioactivity or the radioactive information from the radio tracers that you're given that are in your heart. And so you get pictures like this and the ones we just showed. Here's a different type of scanner. This is actually a SPECT scanner. So the SPECT is a slightly different type of radioactive material that's given. The PET is one particular kind. The SPECT is another particular kind. Actually, in the whole of the United States, usually SPECT is much more commonly done. It's a little faster, a little cheaper than PET CT, but it does the same thing, which is looking again at the blood flow in the heart. These little areas here, these things, the sort of rectangular things, these are the cameras that pick up the radioactivity and can look at the relative, position of the radioactivity within your heart and whether your heart muscle has enough blood flow. And then this donut in the back, that's actually the CT scanner that's used usually in combination with the SPECT. So nuclear medicine tests in general, they're done to look for blood flow to the heart. And so this is really, are there areas of blockages that are causing trouble? You do rest and stress images, and I'm going to explain that a little bit better in a second. And also you usually both for the PET CT and the SPECT CT, which again are two different types of nuclear medicine tests, You usually do those with a CT scan. And so the benefit of that is a lot of times you can also get a calcium score at the same time, which we're going to talk about in a second. So again, the way these the commonality here for the nuclear medicine test is that you're going to inject this radioactive dye, basically, that can be detected by specialized cameras. And that radioactive dye is going to go to your heart specifically and you can look at that activity in your heart to tell whether the blood flow is normal. One thing to note, if you're scheduled for a nuclear medicine stress test, don't drink caffeine the day of exam. And that's going to actually be true for several of these studies. So I'm just going to keep hammering that home for the most part. Don't drink caffeine if you have any of these tests. Okay, so I want to talk just as an aside about stress testing, because people often get stress tests ordered, and there are a couple different ways they can be done. And they're all, good ways to test the heart. Just whether the decision to do one test versus the other depends a lot on the patient, on what they're capable of doing, more so than one being maybe better than the other. So stress testing, the reason we do stress testing is we're trying to look at the blood flow in the heart and tell if there are any blockages that might be causing less blood flow during exercise that could give patients symptoms. So the symptoms would be, maybe when you exercise, you're having shortness of breath, or maybe when you exercise, you're having chest pain. And again, those could be caused by blockages, reducing, limiting the amount of blood flow you get during exercise. So the stress test, what we're doing is we're trying to simulate that exercise that you're getting, that's giving you your symptoms. We're trying to simulate that and do some imaging while we're doing that in order to tell whether or not, the symptoms seem to be caused by blockages of blood flow in your heart. So the simplest type of stress test is a treadmill test. So we're going to make you exercise on a treadmill, and that's going to be the stress. So we're going to exercise you, and we're going to see if we do that exercise and you have the symptoms, and we look for the blood flow, is it abnormal? So then the other flavor, though, is the chemical stress test. So this is for people who really have trouble exercising in particular. Like, let's say you have a bum knee or something, and you can't really exercise very well. You have really bad back pain. So then we can do a chemical stress test, which basically means we give a drug that simulates stress. And in this case, you can give regadenoson or adenosine. They're two different drugs that do similar thing. And then we do imaging after that. So it turns out that there are all sorts of combinations available. The simplest is you get on a treadmill and you put EKG leads on your heart, and we exercise the patient, and we just look to see if there are any EKG changes that happen if the patient has any pain. So that's the very simple one. There's actually no imaging there. Then there's another version where we do the same thing, plus we add echocardiogram. So you do the exercise and you jump off, and then you put the probe on the patient's heart, and you look to see if the heart's functioning normally. And then there's the nuclear medicine test that we mentioned. So you can do a SPECT test with a treadmill. So you exercise on the treadmill, and then we inject this nuclear medicine tracer, and it basically takes a snapshot, more or less, of what's happening in your heart at the time you're exercising. Is the blood flow adequate? And then finally, there's a whole nother group. You can do the same, the SPECT or the PET, with the chemical stress test. And actually, you can also do an MRI with the chemical stress test as well. So again, we're simulating exercise with this chemical, and we're injecting dye, be it a nuclear medicine dye for SPECT or PET, or a MRI dye for the cardiac MRI, and taking pictures to see if the blood flow is normal. So you can see that, looking at the blood flow in the heart is really important when you're talking about doing cardiac imaging. Okay, so now I've got about 6 more minutes, and I just want to talk about calcium scoring, CT, and MRI. So calcium score. So this is a really simple test. Here's some images in a patient from a calcium score. So in this case, this patient has a little bit of calcium in the LAD here, and it's these bright areas that we see show up at the top of the image. Let me see right there. So that's called calcium. So you notice it's about the same brightness as this area here. This is actually your sternum. This is the bone. and here's your vertebral body of your spine. So it's basically, you get sort of almost, the calcification is almost like it's forming almost like bone, or something very similar to bone in your coronary arteries. And so if you have a lot of calcium in your coronary arteries, a lot of times that means that you might have a risk for having some blockages. So we do the calcium score, and you can basically use some computer methods to get numbers on the amount of actual calcium in the patient, and you get a total number down here. So this patient had a calcium score of 173. It turns out that if your scores are 0 to 10 or 1 to 100, it's in the minimal mild category. 100 to 400 and 400 plus are considered moderate and severe. So this patient fell into the moderate category. That would mean that they have a moderate risk of having significant blockages. So just having calcium in itself does not mean that you have a significant blockage that's limiting the amount of blood flow to your heart. But the higher your score, the more likely it is that you will have that kind of blockage. So just by looking at the calcium itself, we can't say whether there's a blockage or not. We can just say whether there's a risk of the blockage and how high that risk is. So calcium scores are really important as an asymptomatic screening test. That means that this is not used to work up chest pain necessarily most of the time. Rather, it's used like a mammogram or like a colonoscopy, where you don't have any symptoms, but we're just going to do the test to look to see if you have any disease. The other way it's really used is to decide on the need to start certain drugs for cholesterol lowering. So these drugs are called statins. Let's say you have a high cholesterol. Depending on whether you have coronary disease, this is what this is called. If you have coronary calcifications or plaque, that's known as coronary artery disease. So if you have coronary artery disease, the target cholesterol level that they want you to sit at is going to be lower than say somebody without coronary artery disease. And so the calcium score can help determine whether you need to be started on a drug to control your cholesterol level. The nice thing about calcium score is that if you have a score of 0, meaning you have no coronary calcium, there's a very super duper low chance that you have any plaque causing blockages. So it basically takes coronary artery disease as an entity off the table, meaning that your risk of having coronary disease is so low that if you say have chest pain a few months down the road, we know that that's not going to be caused by coronary artery disease, because you just have so little plaque that there's no way it's going to be the cause. And so it sort of frees your doctor up to look for other causes. And it's also very reassuring. So it's done on a CT scanner. There's no IV needed, which is really nice. You do have EKG leads on the chest, and then it's pretty quick. Usually the scan itself only takes about a minute. The setup, maybe more like 10 or 15 minutes. And one thing is, do not drink caffeine the day of the test. You're going to hear this a couple of times. Why? Because it increases your heart rate. And if you have a high heart rate, then that means that the images can be kind of blurry. So what's a cardiac CT? So it's the same technology. It's a CT scanner, but now we're giving you dye so we can actually see the coronary arteries here. We can see the blood flow within the vessels. And we're looking specifically at whether this blood flow has any narrowed areas here. Here's some calcium, and here's some other plaque called non-calcified plaque. And both of them in this particular case are causing narrowing of the vessel. We can make cool pictures like this. These are called volume rendered images, which basically give us a map of all the different coronary arteries. This patient actually has had prior bypass grafts. So these are these extra vessels here. So there are some cool things we can do with cardiac CT that we can't do with the calcium score because we have contrast. Here's an example of a patient who has, this is the vessel. This is the main vessel supplying blood to the heart. And we can do these special images to show us that vessel and also show us if there's any plaque. In this case, there's a little bit of plaque right here, but we see it doesn't really cause any narrowing of that vessel. Whereas in this case, this patient has a little plaque right here and it's causing some narrowing. So it's what we call a moderate amount of narrowing. And basically what we can do with the cardiac CT that we can't with the calcium scores, we can see the blockages themselves and whether they exist or not. And that'll help tell us whether if you're having any symptoms, if they're due to those blockages. The other thing we can sometimes do, we don't do this very often, but we can sometimes look actually at cardiac function on cardiac CT too. So you can look at the squeeze of the heart. Generally, this is a lot better seen by echocardiograms that we talked about, but on rare occasions, we may want to use cardiac CT for this purpose. So again, unlike calcium score, these are for patients with symptoms. We're looking for narrowing in the vessels supplying the heart, and that narrowing is going to be caused by plaque. So we can define the plaque, either calcified plaque, which is what we see on calcium scores too, or the additional information we can get out of the cardiac CT, we can now see non-calcified plaque as well, and we can tell how bad the narrowing is. The key thing here, though, is generally we do not do cardiac CT unless you have symptoms that we think might be due to coronary artery disease. It's known that there's no actual value in getting a cardiac CT if you don't have symptoms. One, you would think it would be important to know whether you have any blockages, but it turns out that that if you don't have symptoms from those blockages, there's really no extra information or nothing extra you would necessarily do about them. Important other things to note, you do need an IV and EKG leads. We're going to give contrast, and oftentimes this is a slow process, so give yourself lots of time because we need to give, in many patients, we have to give a medicine to slow down the heart rate called metoprolol, or it's a beta blocker. Because again, we don't want high heart rates, it blurs our images. It's really important in cardiac CT, which is why we give a medicine sometimes to do that. And again, do not drink caffeine the day of exam because that can increase your heart rate. Here's what the thing looks like. Again, looks a lot like the PET CT. It's just this sort of donut shaped thing. And you go on the, you lie down on this board and you go in and it takes pictures. Okay, lastly, before we get to the questions, sorry, I'm a little bit over. This is cardiac MRI. So cardiac MRI is kind of the fanciest of the various techniques that we have, because we can get a really nice look at the different chambers of the heart and how they're functioning. And so cardiac MRI does a great job of showing us all the various cardiac chambers, and also showing us whether the heart muscle is squeezing appropriately. What it doesn't do all that well is look directly at the blood vessels like we saw with the coronary CT. So if we actually want to see the blood vessels themselves, usually we look at coronary CT. Here's some examples. So this patient had relatively normal squeeze of the heart, maybe just a pretty normal heart squeeze here. But then on these patients have heart failure. So this is a more mild case of heart failure where it's not quite squeezing as much as you'd like. And this is a really severe case of heart failure with the left ventricle almost not squeezing at all because of such severe disease. So these patients would have symptoms from their heart failure. One thing we can do with cardiac MRI is we can look at whether or not there's scarring in the heart from an old heart attack. And this is one of the big questions we're often asked. So somebody has a heart attack and they're trying to determine, well, how big was that heart attack and how much damage was there to the heart? So here, this is a set of images called late enhancement images. And what they do is we give contrast dye, and the dye basically goes to areas that have the scarring in the heart. And so this bright stuff here, that's all the abnormal stuff. So this particular patient had a pretty big myocardial infarction or a big heart attack that caused a big scar in their heart. You can also see that here on this injection. We're injecting contrast and taking a bunch of images, and you can see here that let me stop it, that there's less blood flow in this area compared to the rest of the heart. You might just have to trust me, but it's darker there, which means that the blood and the contrast is reduced, and that's because of this big scar. So this is another example. This is a patient with scarring in the heart, which is not from a heart attack, but rather from sarcoidosis. It's hard to even tell what's going on because there's so much scarring, but these bright blobs here, this big bright area here, and also here and here, these are all actually areas of scarring from sarcoidosis involvement in the heart. We can do other fancy things with cardiac MRI. I put this in here because I thought it looked pretty cool. We use this to look at a particular measurement of how much the heart is squeezing. So the software actually follows pixels throughout the heart and follows them through the cycle and gets these really interesting looking images that tell us how much the heart is squeezing and whether it's normal. So there are a whole bunch of different reasons for cardiac MRI. The most frequent one is to look for a cause of poor heart function or heart failure. So it can tell us, are there certain diseases present that might be accounting for this heart failure? Also, if you have abnormal heart rhythms, a lot of time you do a cardiac MRI to look to see if we can figure out why you've got an abnormal heart rhythm. So say somebody has palpitations or something like that. How bad was a heart attack? We do not infrequently, like the one you just saw, to look for the size of the scarring from the heart attack. And then finally, if you do have a cardiac mass, sometimes people get cardiac masses. We look for whether they are a benign lesion, such as blood clot, that might need to be treated with blood thinners, or is it actually like a tumor that might need to be treated with chemotherapy or something like that? Things to know about cardiac MRI, and then we'll go into questions. It's long, so it's a long exam, at least 45 minutes, sometimes as much as an hour. It takes a long time to get those pictures. There's lots of breath holding. So each picture, you have to hold your breath for that picture, and usually hold your breath like 20, 30 seconds. You do need an EKG and an IV. And then finally, the scanner, if you've ever had an MRI before, it's really loud. So you wear this ear protection, it makes a lot of noise, bang, 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 and buzzing, buzzing, buzzing. And that's all very normal. So it's all part of the whole thing for MRI. I think I might have a picture. This is what setup for the MRI looks like. You put this thing on your chest that's called a coil. It's not really shaped like a coil, but that's what they're called. This is actually what picks up all the MRI signals to make the pictures, and it sits on top of your chest. And then you go in the tube like this. Again, all these things are these donut-shaped machines. This one just tends to be a little bit deeper for the MRI. And again, you have a lot more noise, and you're in it for longer. I think that might be my last slide. So I'm going to end there, and then now we can start with the questions. So thanks all for your attention. So I'm going to go to the chat here and start with the first question. Okay, so question number one. I have an aberrant right subclavian artery that goes behind the esophagus. Does this cause problems as I age? I'm 77 years old. Okay, that's a good question. So an aberrant right subclavian artery, that falls into the category of some of those congenital differences or congenital heart disease that you can have. It's not really a disease so much as it's just a different type of anatomy that can happen in some people. And so I would say no, it doesn't generally cause problems as you age. If somebody has the aberrant right subclavian artery that goes behind the esophagus, what can happen is it can cause symptoms of food getting stuck in the esophagus because it's pushing on the esophagus. But those symptoms usually happen at a younger age if they're gonna happen. And if you're 77 years old and you've never had any symptoms before, the likelihood is it's not going to cause any more symptoms down the road. Okay, question number two. What are the best tests when you have had breast cancer radiation to the chest to check on the levels of damage to the heart, the valves, et cetera? That's a really good question. And yeah, breast cancer radiation can cause some damage to the heart. And then actually the chemotherapy, a lot of times that's used for breast cancer can sometimes also, if you have chemo, cause damage to the heart as well. So most of the time, the best way to check that is going to be the echocardiogram, which is nice because it's a pretty easy test. And that's going to let you see the valve function as well as whether or not the heart squeeze, the heart function is normal. Okay, moving on, let's see. So number three, are there any risks involved with having a transthoracic echocardiogram? Not really. You've got your time. There's the risk with any medical test, which would be that you could have, a false positive or a false negative finding. That's always a risk. But as far as the actual test itself, maybe if you don't like the feeling of cold jelly on your chest, it could be a little bit uncomfortable, but outside of that, there's really no risk. And then number four, does calcium score 1450 warrant more cardiac study than a stress test? Well, I would say, so again, the calcium score is something that's used to assess risk overall, but it doesn't necessarily have to trigger another study. Meaning that in general, if you don't have any symptoms suggestive of any blockages in your heart, then most of the time you do not need a stress test or anything like that. Now, if you had some symptoms, some shortness of breath or maybe some chest pain, then a stress test might be the next best step. But if you do not, then having a high calcium score doesn't necessarily mean you need another test. It may mean that you need to be keeping a really close eye on your cholesterol. You may need to do maybe need statins to reduce your cholesterol level. You certainly would need to keep your blood pressure under control. So it tells you that you are at risk for coronary artery disease and blockages, but it doesn't tell you, doesn't mean you necessarily have to have some sort of follow-up test to deal with that. Okay, let's go on to the next question. If I have congestive heart failure with preserved ejection fraction, are any of these tests worthwhile? I am 75 with permanent AFib. Well, I think other than the calcium score, which is, again, like a screening test. So sometimes the calcium score, let's say, I would think about the calcium score as kind of like a screening test, again, like a mammogram or a colonoscopy, where it's helpful to know that information so that you might change your behavior. So let's say if you had a positive calcium score, you have some plaque in your vessels. So that you should really, do your best to keep in your diet as healthy as possible and make sure to keep an eye on your cholesterol, and maybe you have to be on a statin to reduce that. So you do things to help your heart stay safe. But outside of calcium scoring, there's nothing that I've really mentioned today that I would say is worthwhile unless your doctor thinks you need it to answer some question. So for instance, if you have congestive heart failure with preserved ejection fraction, most likely you've probably had an echocardiogram to make that diagnosis. And I would assume that most likely you're gonna, your doctor will treat that with some medication. And you may have a repeat echocardiogram to follow, how your heart is doing. But you may or may not need any more testing than that. So it's hard to say in general that what's needed, it's very individualized what each patient will need. So you may not need anything besides just an echocardiogram. Okay, what are the risks of calcium scoring tests and any other imaging tests? So the risk of the calcium score test is the radiation. And so the calcium score radiation is low. I think in general, our scanner technology has gotten really good. And so in general, all the manufacturers of these scanners have been working really hard to reduce the radiation doses, and they've come down a lot from the early days. In general, as you may or may not know, just living on Earth, you get radiation. We have radiation exposure from the sun. And then we also have radiation exposure from things in our environment. In particular, if you live in a place that has radon, you'll get some radiation exposure. And so there are some numbers out there for what we know is the normal amount of radiation that you get just living on Earth. And usually the calcium scoring test is going to be, we kind of like look at the amount of radiation from these tests relative to that number. And generally the calcium scoring test is going to be a lower radiation dose than what we would call the background radiation dose that you would get in a year. Some of the other tests, it's going to be a little bit higher, but not like a huge factor. So for instance, a cardiac CT test or a nuclear medicine test, those involve radiation as well. And in those cases, usually it's about double to maybe 3 times of background radiation dose. And so although that may sound like a lot, that's actually still well below what we think is a safe amount of radiation for people to have in a year. And just as a follow-up, any of these tests, I think in general, the benefit that you're going to get from the test and learning about your disease is going to outweigh the risk from the radiation. And then the next question was, I'm concerned about the level of radiation involved with the cardiac CT or calcium score after getting several CTs for kidney stones. Can you please address that? Yeah, so sure. So I think, again, when when you get a CT scan or a study for a medical problem, there's always this thing we do called a risk benefit. So what's the risk of the test and what's the benefit you get from the test? And almost as a rule, in almost all cases, the benefit you're going to get out of the test is going to outweigh the risk of the radiation, because the radiation risk is quite low. The other thing to note is that the radiation risk it doesn't add over time. It's kind of a tough concept to wrap your head around, but basically having 10 scans doesn't mean you have 10 times the risk as somebody who had one scan. Each scan is its own kind of event, risk event. And so it's not each time you have a test, you should be looking at that test as an individual risk benefit question. Is the risk of radiation from this test going to be worth the benefit? And it doesn't actually, the previous tests aren't additive. It doesn't necessarily contribute to more risk for the subsequent test. That's a little bit hard to wrap your head around, but that's the way the radiation effects work, because they're random effects. There's not a specific type of effect that happens in every patient. Okay, is treadmill stress test better, or can you see changes more than a chemical stress test? Someone had a negative stress test and 1 month later had an infarction. What can you say about that? Yeah, and so none of these tests are perfect, and in particular, stress tests try to find disease, but there are definitely situations where you can have a negative stress test and then still have something happen a month later, and unfortunately, that does happen. There's no real. I wouldn't necessarily say one test is better than the other. I think you can see if you have blockages, you're going to see them show up in both. In general, if a patient can exercise, you would like them to do the treadmill test, because it gives a little bit more information. It's helpful to know, like in terms of figuring out how healthy your heart is. It's helpful to know if you can exercise for 15 minutes. If your doctor knows that you can do a certain level of exercise, then that's an important piece of information for your doctor to know that, hey, your heart is in really good shape. Whereas the chemical stress test doesn't give us that extra information. So in general, a treadmill, I think, is better if it can be done. But in both cases, you're going to be able to see the blockages if they exist. Now, the unfortunate thing about coronary artery disease and heart attacks is that it's a well-known fact that in some patients, the coronary arteries that cause a heart attack, that vessel is actually doesn't have any severe blockages until the actual event of the coronary artery of the heart attack. Meaning that you can definitely have these situations where you can have a negative stress test and then a month later have an MI. Unfortunately, that's something that happens, and there's a lot of work being done to try and figure out, how to get around that. But as right now, our tools just aren't really good enough to pick up all of those cases. So it's it's not unusual for somebody to have no, I would say it's not unusual, but it's definitely possible that you could have no blockages on stress test, but then down the road you could find that you have a heart attack, because the heart attack comes from a vessel that didn't have a blockage, but then had this event. The event is usually called plaque rupture. So the plaque maybe is a mild plaque, but if it ruptures and nobody really understands exactly why that happens, it ruptures, meaning it kind of like bursts, and that rupture itself causes the blockage in the coronary arteries. So it could go from no blockage to rupture to blockage very, very quickly. And again, that may not be something that could be picked up on stress test ahead of time. Okay, let's see. I had a stenosis of the LAD and a heart attack. Does that automatically mean I have heart disease? Could the stenosis be an anomaly and the rest of my arteries are fine? How is hardening of the arteries diagnosed? So yeah, you do have heart disease. If you had a heart attack, and you had a stenosis, then yes. So I'm assuming The stenosis was probably treated by maybe a stent or something like that. So you did have disease in the you would have probably what we would call coronary heart disease, meaning that the disease is in the coronary part of your heart. The stenosis is not likely to be an anomaly because it would be unlikely to have a heart attack in that case. There are some situations where people can have coronary anomalies that cause a heart attack, but that generally is pretty rare and would happen very early in life, like in the 20s or 30s. So if it's in the other category, if you're more middle age or later and you have a heart attack, then it's almost always going to be due to plaque in your vessels. It is very possible that there could be one plaque in your vessels and the rest of the vessels could look totally fine. So that's certainly possible, and that does happen in people. Or you could have plaque in that one vessel and plaque elsewhere too. It's just the one vessel was the one that was severe enough to cause the heart attack. So the hardening of the arteries it was the second question. And so hardening of the arteries can have a couple different effects. So you can have hardening of your aorta from calcification, and that most often will show up as high blood pressure. That sort of hardening of the aorta, honestly, we don't tend to look at with imaging because we can't really see it very well on imaging. You can see some calcifications, but then there's other hardening that happens without calcification that you really can't see. But hardening of the coronary arteries, usually we think about that as calcification, and that can be picked up on a calcium score. Okay, next question. What are your thoughts on the TAVR procedure? Well, yeah, I mean, the TAVR is a great procedure. And what that means is the transcatheter aortic valve replacement. And TAVR is a fantastic procedure that has sort of come onto the scene in the past 10, 20 years. And it allows somebody to replace an aortic valve that's not functioning normally with a new valve. And you can do it all in a catheter. And so it's great. The old way to doing it was opening up the chest, going on cardiac bypass, cutting the aorta, putting a new valve in. So much, much, much bigger and more risky surgery than doing a TAVR procedure, which is in a catheter. So TAVR is a fantastic procedure. Okay. Best test if you have contrast dye allergy to look for a blockage. Well, that depends a little bit. So if you have you can do different types of stress tests without contrast dye. So for instance, you could do a exercise like a treadmill stress test. You could do the treadmill nuclear medicine test or a treadmill echocardiogram. Those are both possible. Or you could even do a cardiac MRI stress test, are all different tests to look for areas of blockage if you can't get the CT scan because you have a contrast allergy. So that would be up to your doctor in deciding which would be the best test for you. Okay. Number 9, I have cochlear implants. Can I still get a cardiac MRI? It depends, but most of the time the cochlear implants are not MRI safe. So I would say there's a good chance you cannot. But there's actually a website called mrisafety.com. And this website has compiled all the safety data for different devices, and you can look up your device on that website, and it tells you whether or not you can have an MRI. But basically the other thing you can do is you can go to the manufacturer's website for your implant, or look at, maybe if they gave you some instruction manual for your implants and see what it says with respect to MRI. Most of them will be very clear as to whether you can have an MRI or not. But for the majority of cochlear implants, you cannot have an MRI. Number 10, my father died at age 47 of a heart attack or a stroke, but in 1974, cholesterol was unknown to us. He was fairly active cutting grass, yard work was no problem. Should I be worried about my heart health and have any of his tests done? I will be 72 this year, take a statin for cholesterol, some overweight, and can walk a brisk mile on level ground fairly easily. I would say that's a discussion to have with your doctor, but certainly when you have a family history of early coronary artery disease, you need to be careful, and you need to make sure that you are sort of maximizing all the ways you can make your heart healthy. So that includes what you're saying, walking. So, you definitely want to exercise at least 3 times a week. It includes keeping your blood pressure under control and keeping your cholesterol under control. And so all those things, I think given your age and your family history, I think you're already at risk for coronary artery disease. So you should definitely be aggressively treating those different risk factors. The only type of tests, because you don't have any symptoms, the only type of test that you would be really eligible for would be a calcium score, which you could certainly do. And sometimes people like to get that so that it sort of like helps them get some peace of mind, or sort of helps them feel, some empowered with some more information. So that could definitely tell you whether you have a lot of calcium or not. If it was low, then you might feel better, that your risk is lower. But if it was more medium to high, then I'm not sure it really helps a whole lot in terms of, the only other thing you could do is just continue to really be aggressive about keeping your risks as low as possible, meaning your cholesterol, your blood pressure, and getting lots of exercise. Okay, next question. Oops. All right, so next question. I'm a 68-year-old female. I have a calcium score of 126, and in the last few months, I have gone on Crestor and Norvasc with good results. I have occasional chest pain, not upon exertion. My doctor thinks it's vascular spasm. Could this be due to that calcium score? What should I do? Would cardiac CT be warranted? It's if you have a calcium score of 126, then that means you do have coronary artery disease. And so it is always possible that chest pain can be due to coronary artery disease. However, if it's not on exertion, that means it's a little less likely to be due to coronary artery disease. And so I think I have to go trust your doctor that they're sort of made their assessment, and that if it's vascular spasm, that might be the most likely answer. So I think what I would say is, I can't say for sure whether a cardiac CT is warranted, but I would definitely have that discussion with your doctor and see what they think. Maybe they feel super confident that this is not chest pain from coronary artery disease and they don't think you need it, or maybe there's some question and they think it might be helpful to get. It'd be hard to say. I think that's something that would be a discussion to have with your doctor. Okay, so this is the last question for the day. Are all these scans covered by insurance typically? So I would say everything with the exception of the calcium score is usually covered by insurance. The calcium score is more variable, whether it's covered or not. The good news is the calcium score you can pay out of pocket. It's usually pretty cheap. I think usually around $100 or so. So it's not terrible. I think the other scans are almost universally covered by insurance, as long as you have an appropriate indication. So thanks everyone for some really great questions, and I hope this was helpful. Have a great afternoon and a great weekend.